Hear me okay? Video is all right?
Yes, Professor.
Okay.
Yes, yes,
So
Michael.
I'll go over these
Please.
slides quickly and then I'll kind of I realize that people may not have seen this, and apologies for the challenges. But I'm asked to kind of present the current argument related to the role of surgery and the timing of surgical intervention. I have no relevant disclosures, and again, to thank Mitt and to acknowledge the esteemed team of colleagues. So I'll be talking about the rationale evidence for early surgery, and I'll be focusing kind of on evidence underlying the current AFI guidelines. And then I'll talk about some of the controversies in knowledge gaps and also present some of the evidence around central cord injury, some take-home messages. So, the concept of early surgical intervention is really based on the idea that the primary mechanical injury is amplified through the process of secondary injury, and compression of the cord and the ongoing instability in the spinal column enhances secondary injury. And so the idea, which is really based on sound science, that early surgical intervention would be beneficial. And I think one of the challenges has been the implementation of this, but with the advances that have occurred in surgical technique and aesthetic management, ICU management, and so on, we've now seen that that this is a reality we can try to implement. This is supported by strong science evidence, and by this elegant systematic review meta-analysis by Peter Batchelor, showing around a 30% improvement in effect size in animal models ranging from small animals to primates with early surgical intervention. Interestingly, this is largely reflected in the improvements seen with surgical intervention. So I review the Staskus study, 313 prospective patients in North America through the spine trauma study. And in a nutshell, we found that patients undergoing surgery in a mean time of about 14 hours after injury, but within 24 hours, had a almost threefold odds ratio increase of having two or more grade change in the age impairment scale after cord injury. So this study had a big effect worldwide on kind of standard care and care pathways. And then based on this, the first set of guidelines emerged in 2017, suggesting for the first time that early surgery for a traumatic spinal cord injury is the preferred option. But the level of evidence here lower than we would have liked. This is the stringency of the guidelines, largely because there weren't a lot of other studies that we could combine with Staskus, and so we were limited in terms of the quantitative analysis that can be undertaken. So as a result of this, we were kind of inspired to undertake this large study, prospective study published in the Lancet Neurology, over 1,500 patients with all severities of traumatic spinal cord injury. And in a nutshell, we have compelling evidence in favor of early surgical intervention for acute traumatic spinal cord injury. So on the left is a graph highlighting the change in motor score as a function of time. Very clear dose response relationship, and we see this red dot in the first 24 hours. So we see quite a marked effect within the first 24 hours. The histogram has plotted the changes in the motor scores as a function of time after surgery, and again the best outcomes cluster within this first 24-hour time period. So based on this, and a total of 21 studies that we were able to include, we were able to use a key approach for evidence synthesis to formulate new clinical practice guidelines. And these have just come out in the Global Spine journal. And as shown in this meta-analysis, we see quite significant, statistically and clinically significant improvements in outcome at 6 months and at 12 months. And then we see improvements in motor score, as well as a major increase likelihood of a more grade change in the age impairment scale with early surgery, essentially validating the results of the Staskus study. And this shows the changes in the motor score. So on average, around 4.5 changes, motor point changes. And with a patient who's tetraplegic with a cervical injury, quite an important effect. And again, the surgery is safe. Mortality, anything, has a trend to reduction. And so we now have a strong clinical practice guideline. Surgical decompression for acute traumatic spinal cord injury should be completed within 24 hours. Now, when it's medically feasible, and this allows the medical teams leeway to exercise judgment in patients that are medically frail, older, medical comorbidities, the setting of polytrauma, and so on. And it's also recognized that there's substantial physical challenges, sometimes with the transport of just to get there in the first 4 hours. And this kind of brings forward the challenges in the implementation of these guidelines. Now, what about ultra early surgery, which we've defined as less than 12 hours after acute spinal cord injury? And it makes biologic sense. Nothing inherently magic about the 24 hours as a cutoff. It's that this is logistically feasible. It allows teams to stabilize the patients. And this one study from UCSF's providing data to suggest enhanced recovery with ultra early surgery. And this is also reflected in our Lancet Neurology article, where again, this dose response relationship between the timing of surgery and optimal outcomes, with the optimal period being within the 24-hour period. This is a study that was published just as we are completing the guidelines development process, and we do make reference to this article in our global spine. And essentially, this is a study done in Europe where they were examining ultra early surgery in 12 hours versus later surgery. And one of the logistical challenges that these authors ran into was that there was a shift in essentially standards of care in Europe. And most patients in the delayed group actually had surgery within 24 hours. So the difference between this ultra early group and the delayed group was actually quite narrow. Having said that, the unadjusted analysis did point in the direction of enhanced lower extremity motor scores with ultra early surgery, but there's some technical challenges. There were some baseline differences between the two groups, which were challenging to balance, and there was some loss to follow-up. So I would say that this study right now is inconclusive, but it does point in the direction of a potential signal for ultra early surgery. So it makes biological sense, but further evidence is going to need to be required. And now, importantly as well, what about patients, let's say, with a cervical ASIA A injury? And about 44% of these patients will shift their ASIA motor scores and ASIA grades with early surgery. But what about when they don't? Is early surgery still worthwhile? And this is a very nice article from Valerie Terwengel in the Netherlands that we were part of. And essentially, Valerie showed an early surgical intervention in patients with a motor complete cervical injury is associated with a gain of 2 or more motor levels. So for example, let's say like a C5 patient going to a C7 level. That's a big effect in a tetraplegic individual. And then what about central cord injury? And I present this case of a patient with ossification of the posterior longitudinal ligament. And the nature of my practice in Toronto is that it's an extremely multicultural center, and we actually have a high Asian population. We see quite a bit of OPLL and central cord injury, and this is actually becoming the commonest form of spinal cord injury that is being seen in high-income countries as well. This issue is becoming more important. The global burden of traumatic brain and spinal cord injury remains high, and we're seeing a shifting demographic where we're seeing older patients, more fall mechanisms, and more cervical injuries. So this was a propensity-based prospective study, which we published in JAMA Surgery about a year and a half ago. 186 patients with central cord injury, 93 early within 24 hours, 93 delayed surgical intervention after 24 hours. And the overall results did show a favorable benefit of early surgical intervention with improved motor scores. But when you drill down and you look at, let's say, more severe injuries, ASIA C, versus milder injuries, ASIA D, the predominant benefits are seen in the ASIA C more severe injuries. Now, could there be a benefit in the ASIA D population? There could be, but we need to have more sensitive outcome measures to detect this. And so the conclusion from this paper was that early surgical decompression for severe ASIA-C central cord injury was associated with neurologic benefit. And we need further data, I think, to make judgments on the ASIA-D patients. And the technique of surgery matters. Surgery has there's a significant art to doing this. Bijan Arabi's work points to the fact that the quality of the decompression is probably just as important as the timing of intervention. And there's new techniques that are evolving, so the potential use of expansile duroplasty is under investigation currently in the UK by Papadopoulos' group. So take-home messages and future directions. Surgical decompression for cervical and thoracic spinal cord injury within 24 hours of acute spinal cord injury improves neurological recovery. And the 2024 AO Spine Praxis Guidelines, which have now been published in the open access in the Global Spine Journal, does make a strong recommendation for surgery as soon as possible within 24 hours, regardless of level of injury. Now, having said that, there is leeway, of course, to exercise medical judgment, and for the reasons I've indicated, medically frail patients, patients with polytrauma, sometimes when there are delays in the transfer of patients and so on. There's nothing magic about the 24-hour cutoff. In time of spine, the timing matters. So in a young person without medical comorbidities, I think that ultra-early surgery makes sense, especially for an incomplete cervical injury. But as always, there's a lot of judgment that's required. So on that note, happy to close. Sorry about the technical issues with regard to the video, but fortunately, I was able to present this live as well.
Thank
Great
you.
talk. We did a lot, and now Sergio, you can moderate the questions, discussion.
Yes, Professor Zerli. Any questions? No hands raised. I think the 4 presentations were very rich.
There was a couple of questions.
Sergio.
Yes, Professor?
I'd like to...
Oh, sorry. Go ahead, Jody. I'm going to comment on questions in the chat, but go ahead.
Yeah, I think we go with the same line that this ultra early surgery is very interesting. When we were thinking about the first 4 hours of the injury before they go in for the second injuries to take place, if you look at all the research also says that, everything done very early actually improves the patient, particularly in incomplete injuries. So my feeling also same. The last point which you made was absolutely very important, because many times the incomplete one patient, you can see that incomplete injuries they are more likely to improve very well with early surgery. But only thing is that when the patient comes to us, we don't know, depending on the place where we practice, the type of places where the facility is available to, or the patient is very close by to your hospital, who reaches very early within 4 hours or 2 hours time, and provided they are isolated spinal cord injury. It's very interesting point, because I also compare this the infusion of methylprednisolone within that short period of time for us. There is always a point of discussion for incomplete spinal cord injury. I think, Michael, I would like to really want some of you throw some light when
in a sense. So the point for all of us to recognize, and I think which we realize, is that the rate determining impact of a spinal cord injury is the primary mechanical damage. The worse damage, the worse the primary mechanical damage, less likely that there will be improvement either spontaneously or with surgical intervention. And the reason that the outcomes are better with an incomplete let's say spinal cord injury is that you have an underlying substrate that will facilitate greater recovery. Having said that, even when patients, let's say, don't change their ASIA grade, you have the opportunity to recover motor skills. And I think that's an important take-home message, from this. What is the impact on the secondary injury? Well, the secondary injury contributes perhaps 10 to 20% to the ultimate pathophysiology that we can target. But realistically, let's say if we look at surgical intervention or look at, let's say, drugs to attenuate inflammation, like with methylprednisolone, the effects will vary depending on the type of injury. But, overall, we're still going to be looking at, effects that perhaps can be viewed as somewhat modest. So the effect of surgical intervention, based on our Lancet article, based on the systematic reviews, is around 4 to 5 motor points. This, interestingly, is also similar to the effect seen with methylprednisolone, just FYI. In the original thought, all these effects are so small, they don't matter. But that's not necessarily true because it depends on the patient, et cetera. So let's say a cervical patient, 4 to 5 motor points could be a pretty big deal. It could result in hand and upper extremity function, for example. So I would say that, and the other point I'll just make with methylprednisolone is the concerns that were raised, let's say, around the safety of the drug are probably no longer valid. This is we're in the 21st century. Our ability to manage medical complications is so much better than it was 20, 30 years ago. And we have a paper actually that we'll be presenting at the coming ISCOS meeting in September showing that the complication rates with corticosteroids are actually reduced. And, again, suggesting potential beneficial effects, but in subsets of these patients. I think one of the biggest challenges that all of us face, and probably many people on this webinar, relates to the systems of care. And it's probably quite difficult often to get patients to centers within the first 24 hours. And I think, so there's a couple of points here. One is, I think we have an opportunity to look at the systems of care. What can we do to enhance systems of care? And not just in high-income countries, but also in low and middle-income countries. That's one point. The second point is that let's say that a patient does arrive at your center 2 or 3 days after the injury or delayed fashion. It's still better to operate than not operate, okay? Because, although maybe it's not optimal, it's still better because you can get the patient mobilized faster. There still is a potential opportunity to get some recovery of function. I'm often asked that question. So maybe I'll just pause there, but I think Professor Parthiban's brought up, some very important points of discussion.
Thank you, Professor. Any more questions, contributions?
There are questions in the chat, Salvador.
Let me check our chat.
There was a point that was raised by Dr. Caceres. I hope I pronounced it correctly, which I answered in the chat. But this is just around, they're still not convinced of the benefits of early intervention for their disability. Look, I acknowledge the fact that there's groups around the world still don't necessarily buy into even the role of surgery. I was just speaking with a group that were wondering, why are we even operating on patients? And, I think that the landscape has changed. We have much better assessment of stability. Stability surgical techniques have improved. And in terms of the role and timing, I think that, again, if you can get enhanced neurologic recovery, there's very good evidence that it's going to improve quality of life and function. So you can, for example, look at the impact of enhanced motor recovery in the extremity on the spinal cord independence measure, the SIM, and patients have more function. And if you look at the SF-36, health-related quality of life, they rate their quality of life as better. is pretty important, I think. And one of the things I have learned patients is that small effects matter. And I remember we had a patient that was involved in our discussions in the 2017 guidelines, and we were debating the effect of methylprednisolone around, okay, what is the minimal important difference? And what this person said to us, he said, if I can move my finger, I can operate an electrical appliance, a smartphone, and I can have much greater independence. That was quite impactful for all of us. And so I think realistically, small effects matter. But what I would say is that all of these guidelines are guidelines. And the importance of these webinars, and I want to again thank Dr. Zalali and the leadership here of the WFNS, Dr. Rubiano, and others for putting this together, because one thing for Dr. Fehlings and team to write these nice guidelines and these articles and stuff, but how do we implement this, right? How do we actually practically do this? And this still requires tremendous judgment on the part of the surgeons, right? And these are just guidelines. They're there to guide their management, right? And I think as we move forward collectively, we need to think about, okay, how do we raise the bar to enhance this? And at a personal level, I think this is why I feel the WFNS is so important in terms of kind of moving forward, at the international level. And again, I really want to convey my appreciation, very deep appreciation for the leadership of the WFNS for putting webinars like this together and for showing leadership here.
Thank you, Professor. We have a question here from Dr. Pascal, Egypt, about the decompression. You mean the compressive lumpectomy alone, or add dura augmentation?
Yeah, so this gets technique of decompression. So again, basic surgical principles arise. So a closed reduction of a fracture dislocation is a technique to achieve decompression. We do recognize that the cord swells after injury. And so I think it's, let's say, in the setting of a bilateral facet dislocation, if you can get the facets reduced, then I think adding a stabilization and a decompression will be quite helpful. And I think doing a laminectomy with a stabilization, intraoperative ultrasound, which I think is more and more available, is a nice intraoperative technique to assess the quality of the decompression. But if there's a disc herniation anteriorly, an ACDF may be sufficient, but it depends on where the decompression, on where the compressive pathology lies.
Thank you, Professor. Professor, you raised your hand.
Yeah, thank you. I think this discussion is very important and critical. We have been going over every one of the steps for the management of the patient. We have facts now that pre-hospital care is not widely available in many regions of the world. We have facts now that there's so many heterogeneity regarding the emergency care of these patients. And we have facts now that as early as possible, the surgery is beneficial from the patient. I just want to give or have this question for Professor Fehlings, Parthivan, and also for Professor Duma, in order to have the different perspectives, because when we have the first itineration for the bootstrap spine, we have this specific question that is very critical and is recorded of the context. In many regions of the world, you have the possibility to have early imaging of these patients, not all the time and not free sometimes. Some families need to pay for it. But you have the first view of the patient that can beneficiate for early surgery. But what happens is in many regions of the world, the hardware and the system for immobilization is not available in the first, 48 hours or something like that. So the critical question is, if you have a patient that have indication for decompression, but you don't have how to stabilize that, what is your perspective of what to do in this specific case? So want to have the for the three of you.
I'd like to defer to my colleagues. I think I've spoken quite a bit. I'd be very interested in the perspectives of my colleagues, and then perhaps I can have a few comments as well.
Professor Uma?
Thank you. Thank you. That's an interesting questions. From a global perspective or a third world perspective, I think it's a situation we commonly find ourselves in, you know. So a patient arrives at your primary or secondary hospital, and, you know, where we work, imaging, at least basic imaging, not a problem. Basic, I mean, for instance, getting a lateral shoot through X-ray, etc., may not be a problem in the primary or secondary hospitals. And so one can make a determination, here is a patient where there has been a dislocation, where something is necessary. The problem comes from that point. Transferring the patient to the central hospitals where further surgery can be done, proper compressions and fusions can be done. The truth is, you know, there is a serious problem in a country like South Africa, which has got a two-tier system. The system where it's private care for the insured patients, that's not a problem. And so I wouldn't discuss that, because patients who are fortunate to fall in that category will not generally experience the problems which 85% of patients who don't fall in that category will experience. The truth is, many of these patients will come off second best, because there will be delays in transporting them to hospitals where decompression and surgery can be done. So for us that work in the central hospitals, we typically will receive the patient in a delayed fashion. And so you have a patient arriving 24, 48, 72 hours later with bifacet dislocation, Asia grade A, etc. And that's what you deal with. So when the patient does arrive, of course, you proceed and do your best in those circumstances. But you're cognizant of the fact that your results are not going to be anywhere good as they would have been had you seen this patient immediately. So the short answer to that question is we deal with them as and when they arrive, and do our best under the circumstances to achieve a decompression, to achieve a fusion, in select cases, a decompression. Once they have arrived at the touch center, they will then have all manner of investigation that one will be able to see exactly to what extent we are dealing with you know, cord swelling or, you know, facet fractures or dislocations. And so treatment can be rendered, but the delay cannot be erased. So I hope that sort of gives you some insight into what happens in the South African situation.
Thank you, Professor Uma. In Mozambique is the same way. We have the same challenges and the same kind of system. Professor Parthiban?
Yeah, see, India is, you know, very wide, you know. In some parts, we are very advanced. In some areas that we do even have air ambulance. There are in some areas where our patients reach is very fast. In some areas, it is very slow. You all know about the size of Indian continent, and it's all much different. At the same time, even hospitals also different. Where I practice, I have all the facilities. For example, that I have MRI, CT, ultrasound, theaters, emergency care, all in one level. So when I speak it from my viewpoint, we will do the best of international standard at the time when the patient arrives. We do not know how quick the patient comes to us. That's what I was talking about it. So sometimes we get the patient in 2 hours time, sometimes we get the patient in 8 hours time. So it varies to different time zone for the patient to reach us. But the treatment-wise, we follow the international standards. We try to operate the patient as early as possible. It's not only the time, but you know, it's not like some of the developed countries where we have government sponsor for the treatment. In India, many of the patients are they pay by themselves. So there are corporate issues. So one has to adjust with those things. Treatment-wise is the same. In fact, when I was talking to you, I was also discussing about methylprednisolone effects, and we are the one who use methylprednisolone in young patients eligible patient, because as Michael was talking about it, the so-called complications have come down drastically in the past 20 years because the care has gone up. So the standardized treatment is very, very adapted in my place where I work, but it may not be the same thing in a smaller sector. So it's very difficult for me to say what happens in a three-tier city in India. Even in three-tier city in India, there are neurosurgeons who are operating within 24 hours. We adopt to the standard of care whatever the developed countries are having. So within you mean that 24 hours time surgery, all investigations together in one single slot. That is your CT scan, your MRI, everything is done in one way. So it all depending on the place where the patient lands. So I personally feel that we cannot have a strict the regime. It has to be done this way, but a standardization has to be made, and that standard, whenever possible, has to be applied. That's my view.
Thank you, Professor Parthiban. And Professor Rubiano, what's your experience on that?
No, I just
Reality.
was mentioning this because in many places, and even sometimes in our center, we have patients, we have the team there, the hardware is not available on time for the 24 hours. So the question is, you have the possibility of decompress the patient, but you don't have the possibility to fusion it. What will be the best approach? Because you are right to this position. So I am in position of maybe this patient to be offered to the early decompression, but it's all what is the postoperative care that you are going to have over that patient, because sometimes managing patients that does not have fusion is a very complicated case, and you can generate more complications in a patient that you operate with early decompression, but you don't have the fusion techniques possibility. So early also. So that's why I am asking here, because this point was critical when we were doing the stratification for management of care, because this condition is common in many regions of the world. So I want to hear Michael's approach related to that.
So,
Links.
Can I ask
yeah.
Sergio? Yeah,
No,
actually,
I was
first
giving...
of all, I thank all the speakers. They were really very nice talk. Dr. Andres Rubiano, Dr. John Uma, Jyoti Parthiban, and lastly, Michael Fehlings has given very nice messages. I find two take-home messages here. We must operate as soon as possible if we say spinal cord injurations. Is one message. The other one is the intensive care management must also be a part of our routine. Probably in many places, especially in limit countries, it is lacking. We don't much monitor the blood pressure levels. So we must then take on messages that intensive care and early surgery is necessary. Do you have any other comments? Thank you.
I think that's an excellent summary. Time is fine.
Not able to hear. Not able to hear.
Let me try again. Are you able to hear?
Yeah.
Yeah, I think that maybe take-home messages are excellent. I think that what I would add to this is that time is fine. That we need to advocate for enhanced care pathways in all sectors of the world, and to look at practical ways to implement these principles, not just in high-income countries, but in low and middle-income countries as well. So I think one of our challenges. I think Chris's point, I would be hesitant to do a decompression without a stabilization. I think the nursing care would be extremely difficult because with the decompression, you have destabilized the spine and you potentially risk further injury. So I would discourage that. I think it would be better to wait until you had the materials in place. And I'm increasingly aware of the challenges that my dear colleagues around the world face, and it's my goal to try to create the arguments to enhance the infrastructure that you have to provide care for your patients. And my hope is that the evidence you provide, let's say through the guidelines, would, I think, allow us to make those arguments. And then potentially, you know, international bodies such as the WFNS, we come up with consensus statements, you know, this help. And then I think also, you know, trying to address these points. And Dr. Uma, you might be interested to know that I've been invited to South Africa in August to attend the neurosurgical conference there. So I will be speaking on some of these topics, and I look forward to interacting with yourself and other colleagues in South Africa.
Thank you. Looking forward to seeing you. Thank you.
Yes, there was a question from a participant telling that shall we do a laminectomy for decompression? It's not the answer, I think. Must stabilize and make good realignment of the spine. This is decompression, actually. It's an old-fashioned thing, telling that laminectomy alone is enough. It's not that. I think we can complete our session here. Sergio, do you want to add something else?
Yes, no, just to thank Professor Rubiano, Professor Parthiban, Professor Uma, and Professor Fehlings for these excellent presentations. A very interesting discussion, nice topics. I think we still have a lot of issues that are controversial, but the important thing is to discuss and to clarify when to do the things on the best interest of our patients. And thank you for the opportunity of moderating this table to Professor Zeleli.
And I thank also the participants.
And the participant, of course.
Yeah.
The most important ones.
Yeah.
Thank you.
Thank you and goodbye.
Thank you.
Thank you. Nice to see you.
Goodbye.
Bye.
Thanks a lot.